them all. So good afternoon, everybody. It's lovely to catch up with you again. It's lovely to see Palak. We haven't seen each other for quite a while. Now, we've got some questions here, but we're going to do a wee bit of housekeeping in the beginning, as you know that we need to do this. The purpose of these sessions is to ask general questions about PBC and not specific to one's own PBC. That is not fair on our doctors who we're only getting a small snapshot and they can't comment, and that's not fair to do so. And it's also, you're not being fair on yourself. So these are general questions about PBC. If I see something that's going to compromise yourself or our doctor, I will intercept and I will change the nature of the question so as everybody is looked after and we get the best out of these sessions. You happy with that, Palak?
Yep.
Okay, I'm going to start off by saying there's one person who sent a question in, very good question, but we have a panel of medical advisors, and in fact, Palak is on that panel, and this question has been directed to one of their medical advisors. This is something that we cannot put online, that we cannot personalize in any way, and I would ask this person to go straight to their own consultant or the consultant secretary and clear this up and ask the questions you need to ask. I know the consultant to whom you refer, and I know that consultant would want that cleared up and everything sorted. So if you wouldn't mind just contacting the consultant secretary, I think you'll find by the end of the day it'll all be sorted out. Okay, so you know which question that was, Palak. You were sent a list. Okay, we ready? What is PBC? No, I don't mean that. We know what it is. Only nice people get it. We're starting with that premise. So we've got a 71-year-old male with PBC. He was diagnosed in 1998. And he's been on it. Sorry, I've got a dog. He's been on Urso since. LFT remains normal. Great. Over the last 4 years, he's developed, now this is where I won't get it right, splenomegaly. Now 20 centimetres, portal vein diameters 13 centimetres, blood flow normal, echo results, coarse texture, and he's also been cited as having cytopenia, platelets 100, etc. And he's on IgG replacement therapy. He's had 6 monthly bloods and ultrasound. He's had 12 months of fibroscan reading at 4.6. He's been cleared for lymphoma type conditions. Should I be on second generation therapy for PBC is really the question, and that's a bit background. And I don't know how much of that background is relative to the question, to be quite honest.
Yeah. So from just so I understood, I haven't missed anything. 71-year-old person who has been a PBC diagnosed many years ago.
Yeah.
And in more recent investigations, there's been enlargement of spleen size, some cytopenia, which means low cell counts.
Yeah.
And so Collette, was the question as to how that relates to, and the fibroscan value as well, and how that relates to PBC?
He's got 6 months. He does say his LFTs are normal.
Yeah.
So, and his fibroscan is 4.6. But in relation to this problem he's having, he's been cleared for lymphoma, which is great. Should I be on second line generation therapy for PBC?
Understood. That's very helpful. Okay, so just for a bit of context, so when we do fibroscans, for those people who may not have had one yet or don't know what they are, it's like an ultrasound of your liver, but gives us a number rather than a picture of what the liver looks like. And that number, the value, the higher the number, the greater the likelihood is that you've got scarring in your liver. If the value is very high, for example, above 15, 16, the probability of having cirrhosis in your liver is much higher. If you've got a value below 6.57, it's normal. So a value of 4 to me tells me that this individual, together with the normal liver blood tests, they have a normal liver. I'm presuming on first-line therapy with ursodeoxycholic acid. Mm-hmm. In that situation, there is no evidence that adding in second-line therapy is going to do anything. You can't get better than normal in terms of those fibroscan values and blood tests. It is not possible, even with second-line therapy. There is no evidence that you can do better. And even if you can, for example, get even more normal in that range, that it will make any difference. It's just like saying somebody who has got a body mass index of 21, getting their body mass index to 20.5 is not going to make any difference to them health-wise, and certainly going super low is not a good thing either. So the question then is, why is the spleen size enlarging and why is the platelet count falling? It may not be directly linked to PBC in any way, shape or form. That is the first thing to mention. And it's good that this person has had more serious things like lymphoma cleared, but we have to ask the question, what is the reason for it? And the hematologists and this person's gastroenterologist or hepatologist will have to work together to try and find out what the cause is. One example, and I'm not saying that's what this person has, but PBC is an autoimmune condition, and there are other autoimmune blood conditions that can cause enlargement of the spleen and low cell counts, which would need further investigations as to whether that's a possibility, as to why this is happening. And further investigations are likely needed beyond those for lymphoma to identify why.
Yeah, no, that's absolutely reasonable. And good news is the LFTs are good after all these years as well. That's excellent. So further investigation, young man, whoever you are, and I hope you feel that helps enormously. So next question, morning, this afternoon, I just wondered if with PBC, I am able to take Nixol for weight loss, Nixol. I've never heard of this before.
So Nixol for weight. So they're asking about that. Yeah. It's not. I mean, I'm just going to, whilst we're doing that, what I'm going to do is quickly find out what the generic name for is, because Nixol is likely a brand name for something that is not given. So let me just
possibly American, maybe sometimes. Yeah.
Possibly. So let me just have a look. So I'm just going to quickly check what the
detox capsules.
Yes, exactly. So let me just load that up to see what the.
This is another situation where I would say to people, given that you have your own picture with your PBC, you need to be asking your own consultant, but it's a good question to ask to find out what Nixol is.
Yeah.
But Palak would not be in a position to say whether you should or shouldn't really, given he knows nothing about you or your health. Is that reasonable?
Yeah, I think so. Yeah, and I just had a look, and it's something called pramipexole, which actually we use for in some people for things like say certain movement disorders as well, and restless leg syndrome, if it's the same medication that we do. It has been it has been associated in some people with causing flares in liver blood tests, and sort of indirectly. Now it's difficult to predict who gets them. The changes are often very mild, don't cause symptoms, and are short-lived. But so generally, I would say anything that causes any mischief with the liver blood tests, I would avoid. If the other things have been tried or are not appropriate, and if your liver doctor is supportive of it, then yes, you can take it, but with their guidance and approval, provided your liver tests are monitored on it much more closely than they ordinarily would be just with somebody with PBC alone. But I wouldn't necessarily, without knowing much more, use that as a first mode to help with weight loss.
No, I think that's very fair, very individual. Okay, we've got an interesting one here. This person has secondary biliary cirrhosis. Now, I have met one or two in my time, caused by iatrogenic injury to the common bile duct, followed by liver resection, where 5 lobes of the liver were removed. Taking Urso daily, 3-monthly LFTs, results are largely normal with minor elevation of the GGT. She follows the PBC site as her primary diagnosis and treatment seems to be similar to PBC. Excellent. Maybe that's something we could write about sometime, Palak, is secondary biliary cirrhosis, if you feel appropriate. However, I'm not getting many of the same symptoms as PBC, the patient itch, etc. I am tired, but not to the point of fatigue. Does this mean that the symptoms are more related to autoimmune issues than what is happening to the bile ducts? Before you answer that, Palak, can I just say to everybody, I've spoken to hundreds and hundreds and hundreds and hundreds of people over the 30 years I've been doing this, and everybody is different with their symptoms and the severity. You know, I'm a very, very old lady now. In my 30s, I used to go to bed every afternoon, sleep 3 or 4 hours. Now I do workouts. And Palak, you've seen the film of me climbing up the hill on my bike. You know, everybody is different. And some people don't itch. Some people don't get fatigue. It's an absolute mystery. There's some thoughts about it, and we all have anecdotal thoughts, but there is no two people the same. So I'm going to give that to you, Palak. It is a mystery, isn't it?
Yeah, so secondary biliary cirrhosis, what it means is it's an umbrella term for several different conditions. And that is where the bile ducts have been damaged, not necessarily from an autoimmune cause, but in this, akin to this individual's story, and I'm sorry to hear about everything you've been through, injury following a procedure, for example. And similarly, we did see secondary biliary cirrhosis in individuals, for example, during the COVID pandemic, who were very sick in intensive care, long periods of needing oxygen, where their bile ducts were starved, and they developed what we call a secondary sclerosing cholangitis that then progressed to secondary biliary cirrhosis. We've seen it in other individuals who have had other instrumentation to that area, and because of the damage to the bile ducts, not because of a gallbladder removal and things, but for other reasons, they can also develop damage and background damage. Some people are born with blood vessel problems in that area, which travel very closely with the bile ducts that enter the liver. And because of over time, there is a lot of remodeling that goes on at a biological level. Their bile ducts become damaged within the liver, and they develop secondary biliary cirrhosis. So it's a broad encompassing term for a variety of conditions. And what it means is that an external insult outside of your own immune system has then led to scarring and damage to the bile ducts within your liver. So that's one thing that I would sort of that's what it is. We do adapt common principles to try and help bile flow, to limit the damage of bile being stuck within the liver through ursodeoxycholic acid. So urso is, it's a miraculous drug and does many good things, limits the damage from acid to the lining of your bile ducts, helps your bile flow better. And whilst it doesn't dampen your immune system, it makes the bile ducts less sensitive to immune attack, in a variety of ways. So there's lots of good things. So yes, we do use ursodeoxycholic acid. The one thing I would say is that in an individual who's had an insult to their bile ducts in this way, and when that insult is finally removed and the damage has gone away, many individuals reach a plateau where they don't tend to progress, and their liver stays at a certain state and the damage doesn't get worse, which is a very good thing.
Yeah.
Other individuals, over the course of time, their liver damage sort of may continue to progress because a domino has been tipped over and their liver damage continues. It's important to say that liver blood tests and symptoms should not, and similar to PBC, should now in 2025 not be the only thing that we monitor in individuals like this. And the test that we alluded to earlier on in today's Q&A, the FibroScan, is also something that I would advocate, because the blood tests give us one part of the puzzle, and at least once in the clinical course, a FibroScan should be performed. And if it is elevated, then but not yet at the level that we would classify as cirrhosis, so not a very high value, then we would want to monitor it every few years to see if the scarring is progressing, even if it's at a slow level, and even if the liver blood tests are relatively, as normal. If, however, the person has already reached the stage where their FibroScan score is very, very high, already in the range of cirrhosis, then yes, you sort of repeating the FibroScan may have very little value in that setting. And equally, if the FibroScan score is completely normal and is normal over more than one reading over time, and the liver tests stay normal, we may not want to repeat it. But for the vast majority of individuals with any form of scarring, whether they have primary biliary cholangitis or secondary biliary cirrhosis, that middle range, and the doctor should tell you what that range is, don't just rely on the blood test alone. Having a FibroScan is informative because you may need to have other investigations to look for other complications, even if your symptoms are not there. And it's reassuring that this individual, from what, if I heard correctly, does not have many of the sort of PBC type symptoms, but the absence of symptoms shouldn't just be taken as everything is okay and normal.
Absolutely.
Do have a full MOT and ask your doctor about it.
Absolutely. And if we can help any further, please don't hesitate to come back, because as you can hear, we have experts who cover these things very, very well indeed. So the next one, I've got a comment, if I may, first, Palak. My daughter, like me, although I have PBC, has the AMA M2 antibody, normal ALP, however, GGT is raised. Could this be a sign she has PBC? She was discharged from a hepatology clinic and asked to watch her ALP. Now, I don't know who this person is and I don't know the circumstances, but I'm going to say this to you. People out there, many people ask me, should they get their daughter checked if they have PBC themselves? And I would say no, do not, unless you have your daughter, even son, has any symptoms. Do not send your family for random tests for PBC, because if, like this girl, she's got the antibody, she may never develop PBC, but that could prevent her from getting an insurance, life insurance, getting a mortgage. It will hamper her with the finance houses unnecessarily. And it also psychologically and emotionally, it's a very big burden to carry. So I'm not saying that you're in that situation, whoever asked this question, but I would say to everybody out there, under no circumstances, unless there's symptoms, should you be testing unless specifically asked to by a hepatologist. So the question is really, our ALP is normal, although she's got a raised GGT and she's got the AMA. PBC. I'm going to keep this one.
I completely agree. I completely agree with that. The only time I would advocate testing a family member is if they have symptoms indicative of PBC, or because if they have had investigations for another reason that have identified abnormal liver tests, another autoimmune condition. Those type of, you need something more than that, and that's because many individuals in the general population will have not just PBC antibodies, but antibodies that you find more commonly in other autoimmune conditions. But in the isolation, they don't mean a great deal. And what we have seen from big population level studies, and the French groups actually have led on this, about 1 in 16,000 people in the Western population will have a PBC antibody, AMA, without having any evidence of PBC. And of that group, of that 1 in 16,000 individuals, about 16% of people will go on to develop PBC over 5 to 7 years. So it's 16% of 1 in 16,000. It's a very small number. But the point is, it does exist, and we do recognize it. And if the liver tests are normal, and conventional liver tests don't always include gamma GT, you have to ask for that separately. But if the conventional liver tests are normal, it's very likely almost all of those individuals will have a completely normal life expectancy. Only that small group who then go on to progress to develop elevated alkaline phosphatase values or elevated transaminases, other parts of the liver panel, that's the group of people that we would want to treat with ursodeoxycholic acid and treat as they have PBC. That group who have normal alkaline phosphatase and normal bilirubin, normal ALT, AST values, normal albumin, that group of individuals, we would just say, have your liver blood tests checked once a year, even with your GP. And if the other values come up, or if you develop PBC type itch and associated symptoms, then we can see you in the clinic and talk about what else can be done. Gamma GT is an interesting blood test. It is something that is very non-specific. So if, for example, individuals have a very slightly elevated body mass index, that your gamma GT will be elevated. If you have even, say, a couple of glasses of alcohol or a heavy meal one evening, the next day your gamma GT is likely to be elevated. It varies a lot. It is influenced by lots of things. We do measure it in the clinic because there are some people who have elevated alkaline phosphatase values, so this is not relevant to this individual, have elevated alkaline phosphatase despite URSO and other therapies, but their gamma GT is normal. And that's because alkaline phosphatase can be made from other sites, not just the liver and bile ducts. It can be made from bone. It can be made from placenta if you're pregnant. It can be made if children are growing. It can be made from the bowel. And so we check it to make sure that the alkaline phosphatase value is more likely to be from bile ducts and liver-related things. We don't, in people who've got a normal alkaline phosphatase, I don't tend to check the gamma GT or use it in clinical practice, because there's very little data to show that if you've got completely normal liver tests, all liver tests, that isolated gamma GT in itself makes a big difference. Yeah. So I would not label this, as Collette said, she explained it much better than I did. I would not use as a tool for saying PBC. Now, if you've got PBC type symptoms like itching, particularly in the palms and soles, then that's very different. And then yes, you should talk to your doctor about whether further testing is needed. There are other PBC antibodies that you can check for, and if all of these things are positive, then yes, we can have a dialogue about whether it is the start of PBC before alkaline phosphatase goes up.
Yeah, well said. So the next person that they've been diagnosed for 4 years, they've now got mild cirrhosis, they've got varices, and they have significant fatigue, which I'm sorry about that. But we can, if we get time, if we can just maybe be a wee bit quicker, we can talk a bit about fatigue, because we know there's a magic there, don't we, Palak? We know something that works. But I'm sorry about your fatigue. This person on bezafibrate and URSO. And 2 questions, is cirrhosis reversible, which most of us know it's not? And are there any studies showing that it's possible? So we'll let Palak talk about the studies. I've started to feel nausea and lack of appetite when I eat fatty foods, for example, eggs and breakfast. Could this be related to PBC? Whatever you do with your diet, change it. If fatty food is making you feel unwell, then change it. Experiment and come back to me and let me know how you got on. I would like to know more about this. But yeah, just change it to whatever you fancy. You don't have to eat these things. So Palak, so are there any studies showing it's possible to reverse cirrhosis?
Yes, so unfortunately for cirrhosis, cirrhosis is a medical jargon term for scarring in the liver that is not going to go away. Your liver's made of lots of different functioning parts, and when you've got bridges of scarring from one part of the liver to the other of a certain thickness and of a certain sort of type, that's what we call cirrhosis. But you can still have a liver that has cirrhosis, which works completely fine. It's like a car with lots of dents in it, but which runs completely normally and passes its MOT. So cirrhosis in itself is the description of what the liver looks like. And it's important to question your doctor on what basis has that label of cirrhosis been made. That's the first thing I would say, because many individuals historically used to say just based on an ultrasound. Now, an ultrasound can tell you that the liver looks a bit irregular, but in itself, there are other qualifying features you would need to have either on imaging or on blood tests or on other investigations to confirm that you have cirrhosis. Things like a FibroScan. If you have other features on imaging, a bit like the first individual, so an irregular liver with an enlarged spleen, with an elevated FibroScan score, with, for example, low platelets, low albumin, these sorts of things we would want, not just an ultrasound that shows my liver's a bit irregular. So that's the thing I would add in there. Now, there are studies showing that you can reduce the amount of scar tissue formation at earlier stages of their build-up. There is no evidence yet that those studies, it's not PBC specific, by the way, it's just generally in all forms of liver damage, to show that cirrhosis you can reverse. And with the exception of viral hepatitis, which is a different entity, we haven't yet got data to show that reversing cirrhosis is possible. But in viral hepatitis with long-term antiviral therapy, some of that scar tissue has been shown to sort of go down, and so that is encouraging. I'm hopeful that we'll see that with PBC moving forward. Similarly, there are studies now showing that if you even in PBC, in fact, there's a paper that's just been published recently in a journal that I edit, which shows that there are certain predictors that even in people who have cirrhosis with PBC, when their liver starts to decompensate, i.e. fail its MOT, it is possible to predict or estimate the probability of that recompensation, so that regaining of function is possible. And there are tools that are now emerging to show that even if your liver gets to the stage where it's building up fluid in your body, you're having bleeding and these more extreme complications that we see in liver disease, there are ways in which your body can reverse that, so you can get back to your liver passing its MOT. Trials and studies are important, because one of the symptoms, or two of the symptoms, that are really difficult to treat with medicine are fatigue and brain fog. And whilst there is now data to show that certain types of exercises help with both of those things, from a medicinal point of view, we were lacking that. But there is a study that's recruiting nationally. We're recruiting in Birmingham, they're recruiting in Newcastle, they're recruiting in certain sites in London and Nottingham and elsewhere, looking to see whether we can improve brain fog and function. And if anybody wants to take part in any of those studies, speak to your doctor about, this study is called UCAB, that's currently recruiting. And there's another one that's recruiting called OACS, OACS. And if your doctors are not familiar with it, reach out to the foundation, and they can direct you they can point you in our direction or direction of any of my colleagues who do these Q&As. And we can try and find a trial site that's close to you to see if any of these medicines can help. And it's a trial, it's not definite, it's not proven that it will help, but these are the efforts that we are doing, these studies that we're doing to help improve some of these brain fog and cognitive impairment type symptoms. And there'll be other trials looking to see whether we can help your liver improve function, not just improve the liver blood tests.
That is fantastic to hear, Palak. Thank you for raising that. And I think I'll speak to Robert and see if we can get some. I don't know if there's anything on our website, but make sure that we will do. So the next question is the use of statins and I can't say it. Elafibranor. Yes.
Yes.
You can tell I'm not on it because I can't pronounce it. And this person's also on cholestyramine powder for the itch.
He's also on what, sorry? Also on cholestyramine. Right,
Yeah, for the itch. So she's aware that elafibranor can reduce PBC itch and therefore could, in theory, in some circumstances, replace the cholestyramine. However, if you stop taking statins, would it be more beneficial to continue with cholestyramine than to stop that at all? I think it would quite be unfair to ask Palak whether you should stop taking your statins in this instance. I don't think that's quite appropriate. And would you agree with that, Palak? I think this is too small a picture for you to respond.
Sure.
But it's an interesting point being raised.
So statins, for those people who may not be aware, are the most commonly prescribed class of medication in the world to treat elevated cholesterol values. And in PBC and other conditions that affect the bile ducts, we do see elevated cholesterol values more commonly than the general population.
Yeah.
Of interest, the makeup of cholesterol in individuals with PBC is often not harmful in terms of risks of heart disease and strokes and the other bad things. It's actually a good type of what we call lipoprotein, so a good form of lipid and protein combination. So even though the values are high, it's a unique type of cholesterol that individuals with PBC make. So studies done in the 80s and 90s showed that by having those elevated lipid values, elevated cholesterol values, that in isolation was not associated with a long-term risk of heart disease or strokes. So for a long time, we advised that just if you have elevated cholesterol, you don't need to have a statin if that's with PBC, unless you were a smoker, you had diabetes, you were overweight, or you've had high blood pressure, or you had a family history of heart disease or strokes at a younger age, so below 60, below 50 years old. Let me just close my window because there's a cycle outside. 1 second.
Yeah. At least you've not got a dog barking.
But the So that was a long thing, and that's still relatively true. So if you've got an elevated cholesterol with PBC, in the absence of those risk factors, we would ordinarily not advise you to, as in we wouldn't recommend against it, but we would often say you don't need to take a statin. But if you do have any of those things, smoking, overweight, diabetes, high blood pressure, high cholesterol, and or a family history, absolutely take one. As lots of lines of medical evidence go, at one of our international liver congresses in April, May, I beg your pardon, that myself, Robert, and a whole other a bunch of individuals from around the PBC community attended. There was a nice study from Italy, I think it's from Italy, which presented in preliminary form, showing that individuals who took statins with PBC did live longer than individuals who didn't. And that was not just from heart disease and stroke point of view, but from all causes. They just lived longer. And it wasn't liver specific either. It was a general feeling. So that's now been revisited, saying, should I just take a statin anyway if I have PBC? The same thing has been shown in multiple other liver conditions, whether you've got a liver problem from another autoimmune liver disease, or from fatty liver disease, what we now call steatotic liver disease, or from viral hepatitis. Statins have been shown to prolong life, even compared to people not taking them. Now, these are all studies where we look back at individuals rather than studying them looking forward in a very controlled way. We don't know what other medications these people with statins were on. We don't know if they were monitored more closely because they were on a statin, and that's why health problems were identified more sort of earlier. We don't know if they were on statins and the health service, their hospitals and their GPs in that area were better or practiced better than individuals not on statins. There are lots of unanswered questions, so we are revisiting that. So whilst I can't answer for this individual's point of view, I thought that's just a bit of a history of medicine to where statins and cholesterol fit in to the grand scheme of PBC. So cholesterol in itself doesn't always need treating for PBC. So do ask your gastroenterologist, hepatologist, your GP, do you really need it? If you don't have any of those risk factors, but a statin in itself may actually prolong your life expectancy, even for reasons that we don't yet know. And we hope to learn more about statins as we move forward.
Thank you. And we're going to speed it up now, Palak. We're going to give half the code. We've got to get through these. I see things are coming in on the screen. So this lady, gentleman, I don't know this PBC person, they're on urso and they have OCA. And they're asking, is it possible to have an effect on the absorption and retention of iron from a healthy meat-eating diet? Because this person keeps appearing as a problem. So their iron is dropping, which never was the case. And they say when they were young, they're now 69. As a 69-year-old, can I tell you, you're very, very young. We are young. So I'm going to say that to you. I would also say to you, go online and have a look at iron-giving foods. It's not just meat. There's lots. There's another question actually about bones. It's not just calcium. It's not just milk and yogurt. It's in bread. It's in lots of things. So have a look online. So this person saying it could appear a problem from time to time, which is never the case. I think this person thinks it's probably their age, but I think we should suggest this person go back and have them do more tests. Would you say?
Yeah, I think so. I mean, generally speaking...
Briefly, Palak.
Sorry?
Briefly,
yeah.
Yeah.
I mean, generally speaking, when you have low iron values, it's either because you're not taking enough, which is the question, you're not absorbing it, or you might be losing it from an ulcer or a polyp or something like that. And so do go back to your doctor and say, do I need to have upper and lower gastrointestinal investigations? Do I need to have the middle bit in between looked at, which we can now do with various tools? Have a test for things like celiac disease, which occur more commonly in PBC. 6% of people with PBC will have celiac disease, which inhibits the absorption of iron. Take lots of vitamin C, take lentils, take tofu, and if you do consume seafood, these are lots of iron-rich foods as well. But be sure you're not missing a cause of losing iron. Don't always put it down to diet only.
Or age.
Yeah.
Because it's no age. We know this. Right, lovely, thank you. 43-year-old female, PBC for 13 years, now has cirrhosis last year. Random heart rate drops the last couple of months. normal blood pressure, normal 5-minute ECG a few weeks ago. So this person's now waiting on 24 hour ECG. Though GP wanted to ask if there was any known links between PBC, cirrhosis progression, and heart rate function. So briefly, if you can.
No, so I think they're undergoing the right series of tests in the 24-hour ECG, which some people undergo is a very common test. It will identify if you've got any abnormal heart rhythms, any pauses or gaps in your heartbeat which need to be fixed. There's no real link to that, but we know sometimes people with PBC can have. Some people can have, particularly those with fatigue, can have some problems with controlling their blood pressure and feeling a bit dizzy and faint. That's what we call autonomic dysfunction. So if the 24-hour ECG and heart tests are not there, then do ask your GP about something called autonomic dysfunction. We sadly now know that some people who either contracted COVID or had COVID vaccines, some of them do have heart rate and variations, which can be treated with certain medicines. So I'm absolutely not an anti-vaxxer in any way, shape or form, but do ask your doctor about whether that it could be related, because there are things to help. And having a low heart rate is not a bad thing, but if it's impacting you symptomatically, or if there's something that it's going to herald in future, your doctors should be able to identify them and treat them before something bad happens, if that's the case.
Yeah, absolutely perfect. So this person is 47, diagnosed with PBC 12 years ago on URSO, a non-responder. Ocaliva didn't work. Bezafibrate, not really. Extreme fatigue, constant nausea, upper right abdominal pain. Liver consultant is now referring her to a more specialist hospital, think that they may have an overlap autoimmune condition. Is this quite a common thing to see? Also have gallstones, so could this be why I'm not responding? This is another one where this question can't be asked here, but fabulous. You're going to a liver unit, you're going to see a specialist, and they will do every test known, and they will get to the bottom of this. And I do think, would you agree, the gallstones cannot be dismissed here, Palak, that this, there's a picture, the perfect place for them is a liver unit.
Yes, I agree. I mean, gallstones that sit within the gallbladder, are common. About 50% of women with a gallbladder still intact above the age of 50 will develop gallstones at some point. It's something that we see very commonly, and a lot of men develop gallstones too. Both my parents have had their gallbladders removed because of stones. It's a very common thing. Particularly when gallstones move and get trapped in other parts of the bile duct, they can cause abnormal liver tests. If your gallbladder becomes inflamed, it can cause abnormal liver tests. The overlap question is something that we get asked frequently. That's where there are some features of PBC, some features of another autoimmune liver disease. I don't believe that's a separate entity. I think it's more often a more inflammatory, a more immune active form of PBC that, yes, does require different treatment options. Different centers have different experiences. I find that in those individuals, giving obeticholic acid, Ocaliva, which we still have in the UK, works quite well and can help improve the ALT, AST values. But the specialist center you go to will talk to you about that. And again, I don't know which specialist center you're being referred to, but if you need any further advice, the PBC Foundation, I'm very happy to point you in our direction and see you in Birmingham.
Absolutely. Thank you, Palak. And that's marvellous. I know you've done a lot for many of our patients who live nowhere near Birmingham. You've been fabulous. PBC and cirrhosis, general tips and speaking to the healthcare professionals, my opinions. I would say to you, download what's on the website. We have the latest thing that the foundation has done is actually giving you a way of asking questions briefly and to the point. Our website can help you do that. Okay, are you happy with that? Do you want to add anything?
No, I think it's a fabulous resource, and but just have a look at that. But if you've got any additional or more specific questions, by all means, send them into the foundation, and I'm happy to answer them.
But they do. We recommend that you can't expect all doctors to know about PBC. That's just not fair. And most doctors are very grateful to receive information such as ours, which is
Yeah.
heavily read and edited by our medical advisors. You well know, Palak, there's no stone unturned. A lovely question here. Drinking coffee, they've heard, is good for PBC, which, yeah. Does it matter whether it's decaffeinated or not?
No, it's a very good question. So yeah, so no matter what liver condition you have, there is data showing that coffee, people drink 3 to 4 cups of coffee, particularly in the morning, sort of rather than later on in the day, is associated with better liver health. So lower rate of your liver disease progressing. Does not have to be caffeinated. Just to be very clear, it's not the caffeine in it.
Yeah. I love my coffee, I must say, but it has to be in the morning. You start having it in the afternoon, you might have trouble sleeping, just to warn you.
Yes.
So this person at DEXA scan showed borderline osteoporosis, which is minus 2.4. Some advice on the best calcium, vitamins, supplements, etc. Now, I would advise this person to go online again and look at the calcium giving foods, because you'd be really surprised what has calcium in it. As to supplements, I mean, they asked about vitamin D. We're told that everybody in the Northern Hemisphere over the age of 40 should actually take vitamin D. I don't know what other supplements, K, B12, etc. I don't know. Maybe that's something we should be looking at, Palak, at the foundation. Is there a series of supplements that are safe for everybody that we should all be taking, apart from vitamin D? Is there anything else you can quickly suggest?
Yeah, so I think when it comes to bone health, I mean, minus 2.4, I mean, that is very borderline for osteoporosis. Minus 2.5 is what we classify as osteoporosis. So it is borderline. It's good that you're taking those supplements. I can't advise on a particular brand of vitamin D that's better than another, but if you've got very low vitamin D levels, then in your blood, then do ask your doctor whether you need high dose vitamin D rather than just what you can buy over the counter. So that's the first thing. So if you've got low vitamin D, below 30, below 35 in blood, you'll need 50,000 units once a week for 5 weeks before you can even purchase anything over the counter or take anything over the counter. So I'm not going to say there's one brand better than the other. I don't believe there is. I agree with Collette. Calcium-rich food, foods like collard greens, kale, broccoli, are also sort of very good in addition to dairy products.
Yeah, and beg, and so do look online, but chat to your doctor about it, and also don't forget weight-bearing exercise.
Yes,
weight-bearing. Swimming won't do it, although I love to swim, but walking and don't forget that's important too. No matter how tired you are, you can buy into a wee bit more energy. It's been proven, trust me. Latest research about autoimmune disease and gluten. There's a lot about this, not just celiac disease, but all autoimmune. I just want to put a warning flag up here. I hear lots of people saying, "Oh, I'm just going to give up gluten." Celiac is a very specific autoimmune disease, and they say it's people like Robert and I who come from Celtic lineage. Please don't give up any of these things without discussing it with your doctor. You can read an awful lot of things online. Sometimes I want to cut people's fingers off when they go online. Some of the rubbish, some of the myths, some of the fear-mongering things that are online. We're always talking about the foundation and trying to rectify it. Just be really careful. And I just think don't diagnose yourself online. Just speak to your specialist, speak to your PBC person, and if they think it's appropriate, they will send you to a gastroenterologist or send you to an immunologist. They will look at this. Please don't diagnose yourself online. And I know there's a lot about gluten, but how sound that is, we can't tell by looking at what's online how sound that is. I think you go to your own experts and not Mr. Google. What do you feel about that?
No, yes, I agree. And the challenge with excluding gluten before somebody can do a test for celiac disease is if you exclude it, the test will always be negative. So that's the other thing I just wanted to add in there. Now, some people are just more sensitive to gluten, even without having celiac disease. So if that is the case, then yes, okay, avoid those type of foods. I can't tolerate sweet things. I'm not, I just
Me
can't.
neither. And I'm fat. You're slim.
But I just can't now. And just as now, that's not a formal diagnosis. I just don't tolerate it well, I don't react well to it. And you may not react to gluten-containing foods even without that diagnosis. But if you want, but please don't self-diagnose. You need to, because there are other things. And I know we're short on time, Collette, but one thing there was somebody in one of these, I don't know, I won't name them, but in one of the communities internationally, who said that the urso preparations all contain gluten. So anybody with celiac and PBC will stop taking their urso. Now, that's completely incorrect, completely false. I think and when I spoke to them, it wasn't gluten, it was gelatin in the capsules, which is true, sadly, for some preparations. But for some reason, Chinese whispers got out and somebody translated it from one thing to another, and it all went down a rabbit hole. So do speak to your physician about, do you have it, what tests can be done, and how it should be diagnosed before you cut out things. But if you're intolerant to it anyway, and you want it, and you feel better without it, then okay, that's fine.
That's absolutely fine. I mean, they say they're interested in what the science is saying, but again, what do we know is good and what's bad on the internet, you know? So again, just person to person with your doctor. Now, I've got one question left on the list, but I'm going to address some on the screen. Celia says, my GP stopped me taking calcium because I had too much calcium in the blood. Jolly good. Well, that's absolutely fine. Pleased to hear that. A large number of my PBC symptoms, such as brain fog, have disappeared. Celia, that's fabulous. So that seems to be on the back of too much calcium. So interesting. Hello from Louisiana. Hello, Collette and Dr. Palak and everyone that's hello. So we've got one question here, one on my paper. So we've got two, and it is, what does F4 mean in PBC terms? Oh, so F4. Okay, so F4 is a stage of fibrosis, a fibrosis 4. So it's and a bit earlier on in the Q&A today, we were talking about cirrhosis and the way it's diagnosed. So F4 can be labeled based on a liver biopsy or on a FibroScan, and what it means is that the amount of scarring is 4 out of 4. So it is what we would classify as cirrhosis, or on the borderline of having cirrhosis. So that's the level of scarring that they've got. And F0 is none, F1 is mild, F2 and 3 are sort of moderate, and F4 is what we would classify as technically is also borderline as having cirrhosis. Right, okay. And the last question I've got here, and then we can do just a couple of wee tips at the end, because I think it's nice to share some anecdotal stuff. A general question of benefits of FibroScan and ultrasound in assessing PBC staging. Now, Palak, I don't know how you feel about that. As you know, I talked a lot. In fact, James Newberger was on the phone last week, and some doctors are not keen on this term staging. I don't know where you sit with it. I think it's probably helpful to a degree, but it's not black and white, is it? Is that fair? Yeah, no, I think that's fair. I mean, I'm not so rigid about, okay, it's F1 versus F2 or F2 to 3. There is data now showing that if you have a FibroScan score above 10, despite taking a year or so for a year, and even despite having biochemical response, adding in therapy to attain normalization in your blood tests in that high FibroScan score group adds years onto your life. That is there is data now showing that normalizing your blood tests when you've got a high FibroScan score is better than just improving your blood tests. Whereas if you've got a very low FibroScan score, then the old biochemical response criteria that we used to use, improvement below a certain threshold, will still fine. Now you're asking me, is it useful to stage fibrosis? I absolutely think it is useful to stage it. I don't think you need a biopsy to do it. I think a FibroScan can do it. But laboring the point whether it's F1, 2, F2, 3 is less helpful. Knowing whether somebody has cirrhosis, whereas somebody has fibrosis, that middle value, or whether they have none, is perhaps, I think that's perhaps adequate explanation to help influence treatment decisions. Okay, lovely. Just a couple of things I would like to finish with, Palak. For those of you who don't have FibroScans, I don't want you to think you're missing out, because perhaps your doctor's doing what's called an ELF blood test. They're very expensive, apparently. ELF, an ELF blood test. So if you're not having a FibroScan, check that they're not doing the ELF blood test as well. And you can always ask for either of those. So don't hesitate to do that. The other thing, and Palak has alluded to it on a couple of occasions, water, sugar and movement. So yes, good old keep drinking water. We're lucky here in Edinburgh, we go to the tap and we can drink our water. But many people have fatigue and tiredness and soreness because they're dehydrated. They might not feel thirsty, but they're dehydrated. And I speak from personal experience, and I'm sure you've had this conversation with your patients. We don't know that we're not drinking very much. You've got to consciously, I think, drink, and you'll feel the difference. Would you agree with that, Palak?
Yes, completely agree. And don't, substitute water with, very highly processed, sugary, artificially sweetened, so beverages. I mean, I'm drinking a green tea here, sort of, but I think it's, do read the bottles, and things with additives on often give you a bit of a boost, but then you feel a bit more fatigued, and it does make a big difference to when you just change.
You are so right, Palak, and you were making a point about sugar. Like you, just occasionally you have to take it to satisfy a little child's birthday cake, and they don't understand. And how ill and how tired it makes me feel. And I would say to people, there are hidden sugars in food, as you've alluded to in drink, Palak. There's hidden sugars everywhere. I feel sorry for people in other countries than ours that it's just automatically put into the food. So just watch the sugar. It can contribute to your fatigue. And the last thing, and we know this, Palak, and movement is medicine, don't we?
Yes,
and
absolutely.
You did a very successful study, didn't you?
Yes, absolutely, and we showed that in people who had severe fatigue with PBC, and even those with moderate fatigue, there are certain resistance and aerobic exercises, and it's freely available for everyone to read online. You even got diagrams and pictures of one of our physiotherapists showing it. Over as short as sort of 6 to 12 weeks, everybody's levels of fatigue improved significantly. And that's because one of the contributing factors of fatigue is that in PBC, you can't clear acid build up in your muscles as normally as we would need to, and certain exercises, as we've illustrated, do improve fatigue moving forward. I'm not saying it's the only contributing factor and that's the cure for everything, but movement is medicine, and we can certainly lower it and minimize fatigue with those things, with those activities.
Can I give you a wee bit of anecdotal here? When I took up cycling again, maybe 12, 14 years ago, in my 50s, because I used to cycle as a youngster, and I cycled with my sons. And I took it up again, and it was in spring, and every time I went on my bike, I was in agony with what you just get, the lactic acid. We seemed to be able to build it up very quickly, and it was torture. I was coming off the bike, and I was rubbing the back of my legs and all this. That winter, I got a dog. So I'd have to walk the dog every day, no matter what the weather is. And as you know, we can get some rubbish weather up here. I had to walk the dog. But when the spring came for the bike again, it didn't happen. So I think because I consistently kept moving, well, not kept moving, but exercised, if you want to call it that, even a mile walk with the dog, is slowly, in fact, I did one with Bob Geese one day. He came with me just to see, what I could do. And it never happened again. And I don't go out on my bike now. It's in my garage on a roller. But I keep it up, even if it's only 15 minutes. That lactic acid thing is much less than what it ever used to be. So it's worth knowing. Don't let it put you off, people. Just movement is medicine. And, living with a disease like PBC, it can get you down sometimes, you can become worried. And I'm sure you hear this in the clinic, Palak. People get afraid and they don't always voice their fears. But doing just a wee bit of exercise is the wrong word, a bit of movement, something, dancing around to 60s music, your eyes, whatever you want to do, it helps your mood and it helps your body.
Yeah, absolutely. And one of the biggest changes that we actually saw in the exercise program was actually in cognitive function, more so than just in the physical element of fatigue. So absolutely agree with with everything you've just said.
We should maybe run that again in the Beer Facts. I love these things because we get new people all the time. So us old days, we've been there, done it all. They had the pain. We've come to the pain barrier. So we pass it down the line. Palak, you played an absolute stormer again. Thank you so much, Palak. It's lovely to see you. Maybe we'll meet up at some point. I hope so. But all the best to you and your family, Palak.
Thank you very much. Thank you all.
Thank you, everybody. We will speak soon, I'm sure. Thanks, Jacqueline.
Bye.
Bye.